I don't think people understand that that we can screen out people. This is very good. This is very well. I think Dr. Klatch will be like, wow, we can screen out people who have problem with metabolism of Ozempic genetically. So we avoid giving it to them so they don't end up in the ICU with pancreatitis and a blood flow and diabetic mellitus. There is a way that you can find the SNPs for whether this patient will be at high risk of developing pancreatitis from Ozempic. Nobody thought about it. But I think this will be a big program because you can say...
The drug companies won't like that. I'll tell you why. They won't like it because it admits up front that there is problems with their product and that their product is only effective for 50% or 60% or 30% of the population. They'll never go for it from a financial point of view. But it's a smart way of doing it.
I'm asking for the diagnostic. They don't have interest in the big pharma. But it's a pharmacogenetic testing that will determine whether Ozempic will cause pancreatitis or not. And that cause pancreatitis is less than 1%. But we can screen that out. So we don't put liability to the compounding pharmacy who is dispensing Ozempic, and they don't shut down Ozempic because of those cases. I understand your point.
I think a smarter way of doing it, and I'm not arguing with you. I think your plan is wise. I think a smarter and easier way to do it is to come up with a triple therapy and to rotate the therapies so that you're on Ozempic for maybe 2 weeks or 3 weeks or a month, and then you switch to something else, then you switch to something else, you switch to something else. It allows you the organs, the pancreas, the liver, etc., a chance to recover and repair.
I agree with you 100%. That's why we developed the capsule that will have more safer profile, like acarbose. It's coming from a bacteria, by the way. And metformin, everybody used it, and if it's low dose, it's okay. I mean, we're using only 100 milligrams, and then we add naltrexone in it, which helps to stop the craving. And then we add, of course, carbon charcoal or something for the gas, because if you stop absorption of the carbohydrate, the bacteria will ferment it, turn into gas, and lead to bloating. That is being covered with that. And it has vitamin B12 because metformin causes malabsorption of vitamin B12. Vitamin B12 has helped to stimulate energy. And it has quercetin, ACGC, I think. Dr. Mike Emanuel here, he's the one who formulated. And Wells Pharmacy, they are interested in it because they don't want to put their patients constantly on Ozempic. And yeah, so those things, and possibly the big pharma is going to be going after those compounding pharmacies because they're competing with them. But this will be an alternative way of maintenance with that capsule that Dr. Mike Emanuel, which is a pharmacy, is here, right? Dr. Mike Emanuel, are you there?
Yes, I'm here.
And I want everybody here to start trying it. It's just if you go to the ingredients, it's acarbose. It's made from the acarbose originate from bacteria. Metformin, I think everybody knows it's safe because everybody's using it, and it's in low dose. And we do have anything if there's a malabsorption of vitamin B12, anything in mitochondria, we'll put down CoQ10 and quercetin and all that good stuff to counteract that. And then it has some supplement as well. But of course, still you need to have probiotic. The bidiform bacteria, it's a good thing. It does help the Hotanis formulations, because when you add, a cocktail of pharmaceutical, it will be nice to make sure the microbiome is not being altered by those medications. And so add with capsule of Hotan's capsules and with Mike Emanuel capsule, I think we cover all the area. And most of the problem that we have in obesity is the central obesity, is the visceral fat. That's the big problem. And why we have visceral fat? why fat is more into the visceral versus anywhere, because it's the door of the gut. Next to the gut is the visceral fat. And so we know the gut has all the toxins, the microbiome, the bacteria, the toxins, and all that. So any leakage of those toxins, who's going to be facing it? It's going to be the visceral fat, and they get the inflammation there is going to be a little bit higher than any other area of your body because they are next to the door of the leakage of those free radicals. And that's the reason adding bidiform bacteria will help to alleviate the inflammation, because those bacteria secretes postbiotics that is anti-inflammatory and suppress TH17. And it's very important in order to manage obesity and burn the fat. You need to take out the inflammation, oxidative stress, because this will make the cells more sensitive for the Krebs cycle and for burning the fat. Once you have oxidative stress inflammation, the enzymes and the hormones will not able to stimulate the Krebs cycle and burning fat. And those free radicals can interfere with mitochondrial function, and you need healthy mitochondria to burn fat. And so visceral fat is one of the big problem that we need to work on. And that we call central obesity. And yes, stress cortisone does, cortisone does lead to central obesity and visceral fat. Cortisone, a lot of excessive cortisone, what we call it, estrogens, which is the metabolites of the testosterone through the aromatase of the fat. They turn the testosterone to estrogens, and too much of estrogens lead to visceral fat. So cortisone and estrogens are the culprits for visceral fat. They are the one who's causing visceral fat, and we need to work on reducing the cortisone and estrogens by all means. That we're going to talk about in chapter 14 of this book. It will be the most detailed chapter. Another word, maybe the detailed lecture on pathophysiology of obesity, metabolic syndrome, and estrogen dominance, because all those three conditions, they overlap. They overlap in their pathophysiology, in the treatment, in the diagnosis, and we need to study them very well, understand their mechanism and pathophysiology, so that we can understand why patients are not losing weight with everything that we're doing, because lack of understanding the pathophysiology of these three components, of these three pathology, they have some differences and that need to be addressed, although they are overlap in many things. And once we understand the difference and the commonality between these three things, then we can have better strategy to reduce weight. I don't know if Dr. William Clearfield here, but he said that Ozempic sometimes, some of patients are receiving Ozempic and they are resistant to it. And the reason possibly because they are not covering the estrogen dominance that needs to be covered by inhibiting the aromatase enzyme, because excessive estrogens can lead to obesity and can lead to the resistance to response to semaglutides. So we're going to talk about all those medications and supplements that is being used for weight loss, and how we can create a better formula. As Dr. Glatz said, you can alternate between all those things that we are going to talk about. Ozempic,
perhaps something else that should be discussed, not
yeah,
now perhaps, but at another time, is protocols or pathways or philosophies how to reestablish mitochondrial health, how to stimulate mitochondria and brown fat, because it would seem to me and I think it seems to others, that it is mitochondrial failure that leads to chronic obesity in aging. If you look at anybody who's obese, almost certainly their mitochondria are dysfunctional. And so by addressing the mitochondrial specifically, in addition to the weight loss, the appetite issues, you might be able to get a lot further down the field.
Okay, let me even emphasize on that. The capsule that you and Mike Beamer created together, that you spent time crafting it, that anti-aging capsule, it's actually a mitochondrial nutrients, the best mitochondrial nutrient. You put everything, because aging or anti-aging, it's a drug or supplement. Um, Part of it, it's also helps in mitochondrial function. So everything that you put there in your anti-aging is improving the mitochondria. So definitely I would recommend the capsule of the anti-aging that you have, along with the probiotics, along with this capsule, to really cover every aspect. And thank you, Dr. Klass, for mentioning that. Yes, we have in this capsule QQ10 and possibly quercetin, but you cannot do too much in that capsule, right? And so definitely you need to have something for probiotic and a supplement for anti-aging, which also mitochondrial. So if you get this 3 capsule, that will be even better, right? And I agree with you 100%. I think it's a good point that you had here. Welcome, everybody. Today we're going to talk about the book, The Chronic Disease Prevention and Management. I want you to be critical, negative or positive. Our social or our platform is designed for discussion more than one way of teaching. And so I want everybody to ask questions. I don't mind interrupting. In fact, the more I ain't being interrupted, the better for even for the entertainment, because we do have a very short span of attention. Um, I think it's because of the food and the microenvironment that we live in is affecting our brain. And yes, it's putting us at kind of a spectrum of attention deficiency hyperactive syndrome. And by the way, we find out that there is a company who invested good money in putting capsule of methylene blue in A4M for managing ADHD. Well, I think it's attention deficit hyperactive syndrome, and I think it is true, because this condition has to do with neuroplasticity of the brain being changed due to the inflammation of the brain, and I think that leaky gut and toxins that we have receiving from the environment is leading to some sort of brain inflammation and changing the neuroplastic of the brain, making it less flexible in creating circuits of memory, and also it breaks the circuits that connect the dopamine with the interested activities that we enjoy, and that's why we have very short span, because we get bored, and there is no much of rewarding there due to the inflammation suppressing all this rewarding signal for the healthy habit neuronal circuits, which is one of them staying here and listening to this lecture. And so yes, methylene blue will be a good way of buffering the redox and managing and restoring back the neuroplasticity and the connection and the rewarding function between the circuits of the neurons that is giving us the memory and be supported by the rewards circuits of dopamine, so that we enjoy staying and listening and discussing and in this room. So there's a lot of things that we good stuff that we see in A4M. Yes, there are some companies, I don't know how they got the funds, but I would say still A4M is the biggest platform for integrative regenerative in the entire world. I'm saying that with honesty and true, And we all want to support that platform as much as we can. And yes, we need to create a Bible, a board specialty that will be recognized by the mainstream medicine, and use their title that they like. They like CDPM, we use CDPM, chronic disease prevention and management. Um, I think chronic disease prevention management is similar. It's almost the same, like integrative, holistic, regenerative medicine. Um, it's but just using their label. Um, I want to give you an example, but I need the people here to help me here so I can get the analogy very well. What is the term, one word for describing sidewalk? In UK, they have a one word. What is it? Sidewalk. You know, sidewalk in the street. In
Pavement.
UK, they have a one term to describe sidewalk.
Pavement.
Pavement. Okay. So pavement. That's right. So integrative, holistic, regenerative, anti-aging. They're all work in, you know, they have a lot of commonality there, and but they don't like those names for certain reasons. We know why. Big pharma, and all of those therapies help to manage and prevent chronic diseases. But Americans, we cannot use one term. We don't understand that. We need to simplify it for them. So regenerative medicine, integrative medicine does prevent and manage chronic diseases. It seems like Americans, they don't like to use one term. Pavement is not enough. They can't understand it. So they use sidewalk. Yeah, you're walking on the side of the street. So instead of saying integrative, regenerative medicine, anti-aging, you say, no, this is the medicine that prevent and manage chronic diseases. So that's what the mainstream medicine wants us to describe what we're doing in our clinic. It's the American way, okay? Trying to, kind of being sarcastic here, but that's the reality. So what we're doing in integrative and holistic and regenerative, we are preventing and managing chronic diseases, but Americans, they want to have a complete description using those four words: chronic diseases prevention and management, CDPM, which is approved by the AMA as a field that they want to introduce it as a fellowship, as a residency program, as a specialist that deal with multi-systemic diseases, because they fail to manage COVID-19, because COVID-19, this virus, is hitting, I think, every system that has ACE2 receptor, which almost every organ in your body. And because it's multi-systemic diseases, they have a difficulty to define which specialist is going to manage it or prevent it. It's not just infection, it's chronic inflammation, it's autoimmune, it's affecting all the organs and the systems. And it can be a cardiovascular issue, it can be a lung issue, it could be kidney issue, it could be pancreatic and GI issue. And so they got confused there, and they see the gap that as a specialist, we are not being trained to manage multisystemic diseases. And that's the reason the AMA come up with this field of medicine, chronic disease prevention management, to train doctors to know how to manage multisystemic diseases. And that's what we are doing in this field. So I think we are time for us to go ahead and see the book. I need everybody here to be a peer review, which means that I want you to interrupt me if you are lost the chain of the follow-up, because what's important for me is for you to be following up with me and criticize everything that is in this book. I think it's just a demo, and I can send it to everybody here in this room as a PDF file. And um, and you can go through it and see if it needs more language, it needs more detail in certain things, that needs more explanation. That's what I need you to do with me here when we go through the book. Now, the authors are very clear, myself and Dr. Klatz and Dr. Mike Beamer and Dr. Joseph James, and anybody here felt that he wants to be part of this book, I have no problem to add him, especially if he's actively involved with us in CDPM. Maybe the first edition is going to be us, the four of us, but the second edition, I want to have people with expertise in each chapter to even add more to their skills and their cases there and their explanation and their perspective. And that's going to happen in the second edition. Just let's go ahead and launch this version and then distribute it to the doctors of the interest, especially the doctors who are already treating and managing chronic diseases. And then they will say, hey, I'm an expertise in metabolic. The other doctors say, I'm expertise in redox medicine. I want to add more to this chapter. I'm more interested in adding more to the regenerative chapter. And so there is many chapters that is addressing the approach and methodology to manage chronic disease. For a long time, Dr. Mike Beamer was pushing me, write the Bible, write the Bible, write the Bible, write the book of CDPM, show them the protocol. It was going to be difficult for me because English language is my second language. This is one. Yes, I'm born and raised here in the United States, but 50% of my life is here, 50% is overseas. And, to be grammatically correct, I really need people with native tongue English first language to be involved with me. And the other thing is that because of the AI, it made everything easy. Because through the AI and you ask the right questions, of course, you need to have a medical degree to ask the right questions. And if you ask the right questions, definitely you get the right response. A random person who does not have the understanding of redox and regenerative and metabolic and immune modulation, they don't be able, I don't think they can write a book. But if you are a medical degree with understanding of this field of medicine, and they are field of medicine, metabolic pathway modulation and restoration, it's a field. And Dr. William Clearfield is one of the best in this field. And then redox medicine, I can say Dr. Patel, with her environmental medicine expertise, she will be one of the best here, along with Dr. Mike Beamer, because he likes the redox medicine. And Dr. Klatz in anti-aging. It's a combination really of metabolic, immune, and redox. And sometimes it's really difficult to know exactly this condition can be managed by one way. It has to really manage by three approach of four, actually. And that's the pillar of the chronic disease prevention management, is modulation and restoration of the status of the redox metabolic pathways and the immune and regenerative. Those are the four things. And then you can really put all the treatments under this four category. Sometimes the treatments do have both redox modulation and immune modulation, or even three of them, even four. But we're going to learn which is the best way, or what it will be the best category for certain treatment. What is the most effect of this drug? Like, let's say curcumin, I will use curcumin as on the redox, although it has some immune modulation because it doesn't have the TH17. I will not put it as a metabolic because it's really does not replace or any nutrition deficiency or endogenous substance there. Most of the time when you are replenishing endogenous substance or you're modulating the pathway chemically there, then I put it under metabolic. But I think curcumin will be a good category, or it will be placed as a redox and immune modulator, and etc. So, so this is the book. It starts with the contents of the book, and the first thing we have to understand the definition of the chronic disease prevention and management, the need for integrative approach. You know,
Hey,
it's like
Dr. Halassa,
yes,
I don't know if you know, but unless it's just my screen, there's a screen that's in front of the words that you're presenting.
yes. Here, can you see this? This is good.
Oh, yeah, you moved it out the way. Excellent. Thank you.
Right. You know, the need for integrative approach. We know that when we are managing multisystemic diseases, and reality is that all the chronic disease has multisystemic effect, or any chronic disease, it can be aggravated by inflammation of other systems, or by toxins, or by leaky gut. Let's say if you have a patient with diabetic mellitus and you're trying to manage it, you really need to, in addition to find a way to lower the sugar by using insulin or metformin, anything that helps increase the sensitivity of insulin, but also you want to decrease the inflammation and restore the redox. Why? Because inflammation can cause insulin resistance. Oxidative stress can cause insulin resistance, and so if you want to manage metabolic syndrome or you want to manage diabetes, it's not just enough to give them metformin and insulin, but also you need to consider screening all the inflammatory background and the redox status. Where is the leakage of the free radicals? Where is the inflammation? Let's say a patient has leaky gut. That leakage of the free radicals and toxins will aggravate the condition of diabetic mellitus, will increase the insulin sensitivity. So you need to work on manage that part and manage the leaky gut. And we know how. We're going to explain that in our chapters.
Hey, Dr. Alassa.
Yes, can you hear me?
Hey, yeah, quick question. I just wanted to jump in there because it's been on my mind. Is the metabolic, can we deduce it down to AMPK in relationship to mTOR, or do we really need to think of it as all the hormones like thyroid hormone, pancreatic hormones, adrenal hormones?
Yes, metabolic pathway restoration is not just managing hypertension, managing hypercholesteremia, managing the obesity. That's metabolic syndrome. People, they think lowering the sugar, that's managing diabetic, that's metabolic syndrome. But when we say restoring metabolic pathway, we meant by restoring optimizing the metabolism of our body. So if you have deficiency of hormones and you're giving hormones, that's metabolic. You're restoring the metabolism back to normal. If you have nutritional deficiency, vitamin D, and you give vitamin D, that's metabolism. Now,
but can't we break it down? And what's the commonality? Isn't when
the
we
commonality?
Do these things, isn't it? Aren't all of these things amplifying or modulating or favoring AMPK versus mTOR?
Well, that is another topic about AMPK, so and mTOR, because they work in an opposite direction. If you stimulate the mTOR, then you stimulate the proliferation. If you stimulate the AMPK, you stimulate apoptosis and killing the cancer and decreasing the sugar and and killing the inflammasome and senescent cells, and increasing the expression of antioxidant as well. So that's AMPK, what it does. And both is considered, if we manage or modulate this two pathways, it's a chemical pathway in your body, anything that modulate that is considered metabolic. Now, in the process of metabolic pathways, there will be some change in redox and immune, but that's where we need to learn, where we're going to put those treatments under redox or metabolic or immune, although there's a lot of crossing between them. So it's going to be a little bit difficult to challenging, but we will, as a group of chronic disease prevention management, when we write the book, that's where you'll be involved and say, hey, I think in terms of curcumin, it's better to be under the redox medicine. Light therapy, energy therapies, most of them, we're going to put them under redox medicine. Hormone and growth factors and all that, we're going to put them under metabolic. But when it comes into thymosin alpha and beta, that's going to be under immune. So it's, with time, we're going to learn, and together we're going to learn where we're going to place those therapies under which chapter as we go through. The chapters is being written already by the AI, plus with my modifications and tweak, of course. It needs to be kind of edited and make sure that we cover every aspect. And that is where the people involved in reviewing or editing the book and authoring the book with me, they will be engaged in making sure that we cover all the topic and making sure that we classify the treatment into the right classifications. I hope I answer your question, Dr. Juice. Dr. Juice?
Yeah, well, yeah. I mean, I guess that was just maybe a more specific, detailed question is, anytime we increase the hormones, aren't we automatically favoring AMPK in general? Because that's obviously leads to mitochondrial biogenesis, autophagy.
Yes. Autophagy,
okay.
Yes. Autophagy, yes. Mitochondrial biogenesis, that's where mTOR, the proliferation, that is that. So, when you fast and you stop eating sugar, you activate the AMPK when you exercise. And that's killing inflammasome, senescent cells, expressing antioxidants. But then when you start eating, then you start stimulating mTOR to stimulate the growth, right, of the healthy tissue. But after you kill the cancer with your activation of MPK. So it's going to be like, first kill, clean, and then grow, right? You don't want to grow your cells or stimulate growing, and you have cancer and you have inflammasomes. So you want to clear this first. So that's why the AMPK will be active to induce apoptosis of those bad cells. And after you get rid from those bad cells, then when you start eating, what will happen? And sugar goes up, then this will stimulate mTOR for proliferation, right? So killing apoptosis of the bad cells and then start stimulating the growth of the cells. And when you stimulate the growth of the cells, you already kill the cancer cells, the inflammasome. So who's going to benefit from the growth factors is your, that's coming up from mTOR, is your healthy cells. It makes sense?
Yeah, it actually does. Thank you. Because then I guess you could say
so let's say
my
garden.
What's that?
Right.
No, I was going to say,
you have a garden and it has, let's say you have a garden and it has weeds, right? You don't want to go ahead and start fertilizing and giving water because the weeds and whatever flower that you put, they're going to benefit from it. And the weeds are going to start growing and destroy your flowers. So what you do, first of all, you have to know the weeds, right? That's the AMPK. And then you go ahead and fertilize and water your plants. Because my grandfather is a farmer. So I know I have some history of doing some farming. It makes sense?
Yeah, actually, no, that's a very great fine distinction. And then because AMPK would stimulate, say, mitophagy versus mitochondrial biogenesis, but I guess that's a very specific sort of approach to, like you said, pulling the weeds and then fertilizing versus optimizing somebody's overall hormones, testosterone, estrogen, progesterone, DHEA,
integrative treatment approaches, antioxidant therapies, fighting oxidative stress. Types of antioxidants.
Has AI taken over the meeting?
It seems like I can if I don't want to talk, like we have Mrs. Abby here. She likes everything to be digital here. I don't think she likes to hear my voice. I can click this and she can hear the robotic reading it, because Abby is here and she's pro digital ward. And I'm with her. I like the digital. I like the virtual. I mean, without the digital and the virtual, and without the AI, I would not be able to write a book in 2 weeks. It would take me 3 years. So I'm with her. But again, at the same time, do I have an echo here? Am I having echo? Okay. At the same time,
I'm here.
Yeah. At the same time, hey Abby, how are you?
I'm doing well.
So at the same time, we want to make sure that the technology that we put, it's because it's like a sword with two edges. Sometimes it can complicate things. And so that's the reason we're going to help her, hopefully, to at least prioritize what needs to be done as a priority. And she's very intelligent. I understand. I'm a person who like I'm her in a personality. We are both INT. I'm P, but she's J. And yes,
I would you said be critical, right? I typed her as an INFJ. It's done deal.
I think she's an INTJ.
It's done deal.
I did send her the link, and I told her
INFJs
okay, how
are
about
logical.
That? You want to bet?
But she's an empath. She's an empath. I know
you're the master. I know you're the master, and you teach me this, right? And I cannot really put much there in challenging you, but I want to give you the $100. Accept the bet. I want to give you the 100 because I know you're going to win. But convince her to take the question. Then you get another $100 to convince her, and then you can split between you and her. Just say, "Hey,
I'll answer it."
Done deal.
Is that done? Okay.
Done deal. Good. Yeah, I'm in.
Okay.
Done.
So here we go. Let's go back to so we understand that we need an integrative approach to manage chronic diseases, like a tire with many holes. You cannot go ahead and say, "Hey, I'm going to patch one hole and manage and keep that tire inflated." So we need to screen for all the free radicals generators, all the inflammatory sources, and then we need to patch them. And as a human, we have many leakage in our body. We have the leaky gut, that's one, the toxins, that's second, the infection, that's third, underlying chronic disease, that four, and name it, deficiency of nutrition, the problem with your sex hormones. All of this can be source of inflammation that needs to be screened and needs to be optimized. And so we're going to look at the overview of the book structure as we are doing now. Then we know that the chronic disease prevention management, the approach that we are taking, I think all of you here as a CDPM, is the 4 pillars, right? Any religion, any faith, they have pillars. Christianity, they have pillars, right? You have to believe in God, sacrificing Son, and the Holy Spirit, and all the Trinity thing, and Jesus is the Savior. Those are the pillars of Christianity. For Muslim, there's only one God. You believe in all the prophets, including Jesus and Solomon, all those, and you pray and you fast, and there's 5 pillars there, right? And then the Judaism also have their pillars. And CDPM, as a book, as a field, as a specialty, it has pillars. It has a way to manage chronic and prevent chronic diseases, is by restoring and modulating metabolic pathways, so that you don't confuse between metabolic pathway and metabolic syndrome. All the metabolism of the body needs to be optimized. And restoring and modulating the redox. Why not just restoring? Why not just say neutralizing free radicals? Because if I want to kill cancer, I may need to induce free radicals in the cancer, so I can induce apoptosis, increase the free radicals there, right? And pathological increase, so I can kill that cancer cells or kill that infected cells. So I like to say modulating the redox, which include also neutralizing the free radicals for the healthy tissue. And then also we need to modulate and restore the immune system. Why not just restore? Because we need to modulate as well. If you're having cancer, you want to modulate the immune system and shift it to Th1. and inhibit Th-reg and or Treg and Th17 and Th2. If you want to treat allergy, you do the same. You move all your immune system into Th1 or to Treg. If you manage um, autoimmune disease, which is Th1 dominant, possibly Th17, then you want to modulate the immune system into Treg and Th2. So it's not just restoring, but also there's modulation here, where you, by attention, shifting the immune system from one side to another to manage all this immunological conditions. And so those are the four pillars, including the last one is regenerative status. If you finish optimizing the metabolic and the immune redox, then you start working on how I can restore the regenerative status. Let's go ahead and do stem cells and exosomes and all the things that we talk about. But try to manage the regenerative status, the last thing you do after you finish optimizing the other three. Because you want to put your seeds in a healthy ground, not in a dirty ground of the regenerative. And so we're going to understand the redox status, redox potential, the role of redox in health. The reality is that redox control almost all physiological processes in your body, almost all of them. The metabolism, the energy flow, or the flow of energy, the electron transport chain, the electricity in your body, your sleep cycle, your apoptosis, your proliferation, your circadian rhythm, it's all controlled by redox potential. And we need to distinguish between redox and pH, the hydrogen potential. That's going to be in the book. The impact of oxidative stress, and again, not necessary that we're going to have a full-blown inflammation, because that's the reason I don't use inflammation. If somebody has Alzheimer, people that use inflammation, the brain, I like to say oxidative stress, because inflammation means, the sign of inflammation, swelling, edema, but you can have oxidative stress, rusting, and gliosis without that sign of inflammation. So sometimes if it's subclinical inflammation, which means not manifested as a clinical inflammation, I like to use oxidative stress versus inflammation. And so we're going to understand the impact of oxidative stress, the redox balance and chronic diseases. Most of the chronic diseases has abnormal redox potential or abnormal redox that needs to be modulated and restored. And we're going to talk about that in the context of conditions and clinical cases. Metabolic pathways, again, it's not meant metabolic pathway, the metabolic syndrome only. It's not limited to managing diabetic and hypertension, obesity, and hyperlipidemia. It involves restoring and optimizing the metabolic pathway of your body, whether it's anabolism or catabolism. And so if there's any metabolic dysregulation from deficiency of nutrition or vitamins or hormones, that needs to be recognized or detected by your diagnostic approach, screening all of that, and then start replenish them, right? The strategy of metabolic health, optimizing your metabolism. We're going to learn that in this book. Also, the other pillar, which is the third pillar, is modulation, restoration of the immune system. If I want to fight the virus and infection, especially the viral infection and cancer, I will move the immune system to Th1. If somebody has rheumatoid arthritis and they have overactive Th1 and Th17, then I will modulate the immune system to Treg and Th2. That's how we manage immune disease instead of suppressing them with cortisone. It's better to modulate the immune system, because if you treat immunological disease with suppression using cortisone all the time, you put the patient at risk of having cancer infection. It's better if we can modulate. It does not mean we are not using cortisone. Sometimes you have all those immune systems all flare up. And at that time, you want to use, low dose cortisone to kind of reset the immune system, and then start modulating it to the favorable direction for the health and of the patient. So we're going to understand that all chronic diseases do have some immune regulation, including degenerative diseases. They do have some sort of subclinical immune dysregulation. And we use a lot of naltrexone for that. Most of the inflammation of the neurodegeneration, they will have some overactive Th17 and some Th1. And I think we need to give naltrexone to modulate that. Of course, the main pathology of neurodegenerative diseases or degenerative diseases is oxidative stress. And so by restoring the redox balance, we can slow the process of the degeneration, including immune modulation and then regenerative status. And yes, if you have any deficiency and any problem with your metabolism and your 6 hormones or vitamin Ds or anything of that, definitely that's part of it. So if you see that any chronic disease out there, they most of the time they have those 4 pillars that needs to be addressed. Regenerative medicine, the future of healing, principle of regenerative medicine. We understand regenerative medicine is stimulating the endogenous stem cells or giving them exogenous stem cells from outside or from autologous and just, kind of autologous stem cell therapy is basically moving your stem cells from your bone marrow to the area of the interest, right? And normally that's what's happening. When you get injury, your stem cells goes from bone marrow or from the fat stem cells and goes to the injury. But it's not that enough. So we go as a doctor and take more and move them to the site of the injury. That's what we do. But basically that's what's happening. But we can do more by taking it and purify it and just put it to the site of where it needs to be. Principle of regenerative medicine, application in chronic disease management. Yes, there's many applications for it. Almost all chronic disease may need ultimately some regenerative therapy. We're going to have some case studies and patient outcome. I think we have enough of doctors here who may share their patients' reports, or we can use the AI to give us the publications and the reports that's already being exist. The interplay of systems in chronic disease. Very important to know that chronic diseases, most of the time, they are multisystemic. Like if you have diabetic, it's not just that the pancreas is not producing insulin and you have sugar high. If that's the case, we have sugar high. Sugar is a free radical generator because they get oxidized, they become glycans, so it's a toxic in your body. And it's a free radical generator, means it generates free radicals in all your body, right? And it leads to neuropathy, it leads to cardiovascular diseases, it leads to suppression of your immune system, dysregulation of your immune system. So you really, and what aggravates diabetic is leaky gut and toxins and fungus. And so you need to really address all of this to manage that. Yes, go ahead.
Sorry. So I'm assuming you mean like processed sugar or like added sugar? Like, because what about sugar from fruits? Diabetic, like, is all sugar bad?
No, even diabetic, the sugar, if it's not being controlled by your insulin and you don't have enough insulin produced by your body and you have excess of sugar in the blood, the regular sugar, those sugar will get oxidized and they become glycans and they become free radical generators and toxins. Too much of sugar. That's why we need to lower the sugar in your blood to the optimal level. And the idea, this is what's happening. One of my uncle, he said, "Oh, I don't like the tablets, the metformin. It just causing me a lot of problems. Weight loss and skin to bone and loss of appetite. I like the insulin." Told him, "Why you like insulin? Although metformin is more safer than insulin." He said, "Insulin, I can eat sugar and then I can inject." Do you know what he does? He's burning his body because it's like adding gas and fire. When you eat sugar and the sugar goes up, that sugar itself will oxidize, become free radical and cause all inflammation. And then if you inject insulin itself is toxic. Insulin itself, it stimulates those cells when they push the sugar in, they stimulate oxidative stress. And so really, it's like putting gas in the fire. And I don't recommend people doing that at all. You know, if you're diabetic, try to reduce your carbohydrate diet. And if you can't, you can use the capsule of Dr. Emmanuel, which contain acarbose that inhibit the absorption of the sugar from the beginning. And that may help if you are craving sugar and you cannot stop it, then possibly this medication of acarbose is better than insulin, of course, because it does not work inside the body. Acarbose, it works in the intestine, preventing the amylase from breaking down the carbohydrate. Any questions? Everybody is happy with the way we structure the book? Yes.
What about like somebody who doesn't have diabetes? Like, I'm just getting at diet in general and like sugar and like.
Well, the sugar in general, the less you use, the better. Low carb diet, for the sake of the health, because when you eat sugar, you have a spike of sugar that will turn into free radicals and start oxidizing your body. So that low sugar itself will decrease the amount of the oxidation and helps to decrease the aging process. So you live longer. Don't you like?
But what about like sugar and fruit?
Yeah, that's the way to go. Sugar and fruit is the way to go.
It's, right, sugar and honey, fiber and matrix. Especially if you're not diabetic, though. If you're diabetic, it's another question. But if you're not diabetic, you can replace the sugar with honey, but reasonable, not like, you know, only fruit. Yeah, as long as your diet is mixed, I think it's okay. Because what happened is the fruit and the honey, they have a lot of polyphenols, which will help to counteract the sugar oxidation. So you're not giving just sugar, but also you're giving antioxidant that help to neutralize the free radical. So it's balanced. I think it's okay to go that path if you're not diabetic.
Can I add something just to, I think this will tie it together. So is it possible that because we're dealing with so much inflammation and oxidative stress in general, just from everything that's coming at us, you know, the
environmental toxins, yes,
the environmental toxins, and that we have to be maybe perhaps more vigilant, almost seeing ourselves as pre-diabetic or predisposed towards diabetes or pre-diabetic, or we have to, it's almost like being diabetic where we have to be extra vigilant with the sugar because it's going to exacerbate an already inflammatory state for those who are, you know, dealing with, I mean, most of us are dealing with a level of inflammation and oxidative stress with just the environment that we're in, correct?
Yes, and the environment and lifestyle. When God created us as a human, he really created us as more of labor, expecting that we're going to do hard work and lifting weight. He did not create us to be sitting at a table. That's not what's being programmed in our body. And that's why for people who are doing the office work, they go to the gym. But in the you know, those labor people who are working in the farm or building or whatever, they are burning those sugar they eat. And so they get rid from it. But for our lifestyle and environment that we live in the city, then we don't have the choice here. If you want to live that lifestyle, sitting at a table in front of a computer, including myself, then you need to change your lifestyle, and that will counteract this, you know, the toxins and the additives in the food that we have, and the plastics and all that, which we're going to talk about them in the chapters in detail. So yes, so you know, we have to understand when we manage chronic disease and prevent it, you're going to be different from specialists. Specialists, they focus on only one system and they don't cross the line. If they cross the line, the other specialists will start complaining. When you become chronic disease prevention management with the cover of the AMA, that you are trained to do this, hopefully we'll have the funds to get the CME, the fellowship, the residency, where you got the certificates to justify that, oh, you know, yes, I am a cardiologist, but I'm also certified CDPM, so I can take care of rheumatoid arthritis. And to piss off the dermatologist, say, no, I'm just increasing the quality of life of the patients with rheumatological diseases. Just don't say treating rheumatological diseases, but say I'm improving their quality of life. It's all about politics, how you use the word. But the reality is that your approach of managing inflammation or chronic disease, whether it's rheumatological disease or cancer and all that, it's going to be better than us, because we know that those conditions are multisystemic. The body is all connected. And yes, we come up with a field called integrative. It's the same thing, but Americans, they don't use one word. They don't like that. They don't understand it. You have to explain exactly what that word is, right? So it's sidewalk. It's not pavement. Pavement, right? It's a sidewalk. Side and walk. That's how we understand that. Okay. Anyway, so that's the meaning of integrative medicine. So we need to use the integrative approaches. We need to screen all the free radicals generators, all the inflammatory sources, and start managing them. And yes, antioxidant, this chapter is supposed to be under redox medicine, but I think we're going to talk more about the antioxidant versus modulation of redox. And we're going to see the types of antioxidants, clinical applications in CDPM, neutralizing the free radicals, and evidence-based antioxidant strategies, right? Which include all the supplements, possibly things that helps to increase the expression of the antioxidant enzymes. So some supplement, they directly neutralize the free radicals, but also some supplement increase the expression of the antioxidants. So we're going to study that. And yes, there's a lot of overlap on those chapters, like nutritional intervention. They are optimizing the metabolism, redox, and possibly the immune system. And the role of diet in chronic disease, in general, low carb diet, and rich green with vitamins and amino acids. The nutritional guidelines of CDPM, case studies and dietary interventions. We're going to talk about that. Very important is lifestyle modification as a preventive of chronic disease, and also treatment. Lifestyle modification is not just prevention, but also treatment. The exercise, stopping alcohol and drinking, and all the exposure to those harmful toxins, sleep well, managing the stress, implementing and maintaining lifestyle changes. That's the reason when we want to put a medical center for chronic disease prevention and management, you really need to have everything in that center. You need to have a compounding pharmacy there, putting together the protocols, formulation for the protocols. You need, when you inject the body with pain management, and that's the problem with pain management. Pain management clinics can be a source of pain and a state of managing pain. Can make the pain worse, because if you just inject the patient with steroids and numb the area, that's not the treatment. Even if you inject the stem cells, you still need to work out to increase the strength of the structures around that defected joints. So this therapy helps to make you more comfortable to exercise, and the exercise has to be anti-gravity exercise where you don't put stress on your joints. The best exercise as anti-gravity is aquatherapy. So if you want to put a medical center that addresses pain management in the right way, you have to have injection and then physical therapy, and especially aquatherapy, not lifting weight. But it's best, it's going to be anti-gravity exercise where you don't have impact. That will strengthen the tendons and the muscles and ligament around the joint, and they will kind of replace the joint, the pathology of the joint, or the defect of the joint, or replenish or complete or cover the defect of the joint function with strengthening the muscles and the tendons around that joint. So the real treatment is the exercise and strengthening the muscles. The injection just to give you the patient to be comfortable to do those exercise and can sleep at night, because sleeping is very important. It's the best detox system in your body. Advanced regenerative technique. We're going to talk about all the cutting edge and stem cell therapy and exosomes, platelet-rich plasma therapy, and we're going to also talk about what we call the biological nanomedicine. That's my field of interest and the forte, is that I believe instead of giving platelets therapy as platelets, it's better to break them down. Some of them they call platelet lysates, but I don't like to call platelet lysates. I like to turn it into platelet nanovesicle and load them with drugs that we need to manage the joint. So platelets nanoparticle. That's called biological nanomedicine. And you can load those platelets with drugs after you break them down with extrusion and filtration, and I think we have a couple of doctors here who are being trained already for doing those things. I think it's way better when you want to treat a joint. It will be good if you take the platelets and you break them down into vesicles and clock the drugs like cortisone and when you want to add lidocaine, or I like prilocaine over lidocaine because prilocaine is anti-inflammatory and regenerative. Lidocaine is a little bit toxic to the stem cells. And you load those platelets with positive peptide if it's allowed, oxytocin. If you have a problem with the peptide, you can use oxytocin. Oxytocin is a replacement for all the peptides out there. In case they shut down the peptides, you can use oxytocin as a replacement. Add vitamin B12 in your methylene blue if you'd like. And then we're going to talk about ethical consideration and the future perspective of it. Of course, it's very important that the treatment that you are directing to the patient has to be personalized, has to be based on comprehensive data that you collect. In comprehensive data, I think the best approach we can adapt the American Medical Association, the HB 360. They give us really the whole scripts, the format to collect comprehensive history from the patient, and in addition to the physical exam. So we're going to adapt that American Medical Association CDPM 360 HB, and we're going to ask Abby to put that in a digital. I'll digitalize it in her mirror. She has a mirror, and where that digital mirror, when you stand in front of it, the mirror will, that robot in front of you will start asking you ask the patient questions that is being dictated by, or it's being formatted by the American Medical Association, the 360 HP. And it's going to be audio and turn into script. So once you see the patient, you have all the history, at least the history there done. And then when you do the physical and you recommend a diagnosis and treatment and whatever you want during the course of interview with the patient or examination of the patient, then you will have a system, and instead of having assistant, writing behind you, you will have that little phone reporting or turning all this conversation into medical report. So we don't spend time, which almost 60% of our time, writing that damn report and treating documents instead of patients. That is my wish for Abby. She's here, and hopefully she will understand that unmet medical need. I mean, she's doing very good, but if she can focus her energy into what the doctors need, and we need to learn this. We create products around medicine, real medicine. We don't create medicine around products. That's a big pharma, what they does. They create vaccine, they create whatever, and then they make a fake medicine around that to push that product. We want to be real here, and we want to both use mainstream medicine protocol, integrative protocol, both sides, label and off-label. What is best for the patient? All the labeled drugs, they're good. Some of them are being paid to be good, to be approved, and with long-term use, it's going to be toxic. But that's the reason they shift from off-label to label. Part of it is the money that they put. It's not much of the outcome. There is some outcome. Of course, you have to prove it. There is some outcome. But if you pay the money, then even the some outcome will be approved. But there's a lot of good and off-label, like good. But there is no money to take it from off-label to label. There is nobody's paying the FDA and doing clinical trials that justify to turn it from off-label to label so that it stays off-label. As as we need that physician autonomy. We are the one who determine what's the best from both sides of the aisle. And you have the authority to do that. You can use the off-label. As long as the off-label is approved by FDA as an ingredient that has safety, then, and it's been used for the humans, then you can change the application from one side, like Metlam Blue is being used for methemoglobin, but also you can use for off-label as COVID. Just make sure that you have a nice consent. And that consent too, I think she can digitalize it if it's allowed by legally, at least, and then the doctor will just sign the paper at the end or put the digital signature there. And that all can be digitalized and make things streamed out. That is what I will recommend Abby here to do if she is interested in my vision. I'm not asking her what to do here. I'm asking her, this is our vision as doctors. We're hoping that you take the vision of the medical necessity and medical need as a priority in your program. That's what we're asking for. Assessing individual patients in need, that's very important when you are doing personalized medicine. You take the data from that person. You don't treat all patients the same way because their data that you're receiving is different. The lab is different. Their genetics is different. And so when you treat them, you have to treat them based on their genetic makeup, based on the data, based on their psychology, based on there's many things to be considered when you are providing the treatment. And that's called personalized treatment. And very important, when you give the treatment, you want to make sure that the treatment works, not just by normalizing the level of the metabolic panels, but functionally. You want to know if the patient is functionally fit, is functionally optimized, not just chemically optimized. And function optimized, what I meant by that is using heart rate variability. That's a good one in the Theo function test. That's the second one. This two things can help you whether your treatment did actually neutralize the free radicals. Because if you give those treatment and still you have a problem with your heart variability, still you have sick autonomic nervous system due to the inflammation, oxidative stress, still you have inflammation in the endothelial. So there's something missing. Whether there is another source of free radical is causing this problem that needs to be screened out and managed. Because the treatment that you did, yes, you optimize it, which could be a factor, but it's not everything. It's like a tire with many holes that you need to patch all the holes. Otherwise, you cannot really restore the endothelial function and the ANS effectively if there is another hole of free radical or source of inflammation. Number 12, case studies in chronic disease, real world example of CDPM in action. Me and Dr. Jusuf, we're going to work on this. But I'm open for any contribution here where we have clinical cases, real ones, that we can add it in the book in the way that we use the 4 pillars of the chronic disease management approaches in managing these diseases. Lesson learned from the patient's experience, the outcome, and this autonomy from the patients will be good too. Insight for the practitioners and the patients. All of that, we will try to put it together, whether from the data that's already exists out there or from the data that we can get it from us as CDPM physician. The future of CDPM, emerging trends in CDPM, and there are many trends there, especially in diagnostic area, because it's personalized, it's based on genomics and nutrigenomics and pharmacogenomics or pharmacogenetics. All our treatment is personalized and tailored to the data that you receive from patients, from his lab, from his physical exam, from the history, from the environment of the patient, from whatever he's been exposed to, from the stress at work, from the problem with the family, all that. We come up with the plan, because it's not enough if you give all this management, the patient is being stressed out because he has a partner that is not fit or has a problem with or work or finance, or they cannot make money for a living, and you don't manage that. The stress itself can produce enough of cortisone that will suppress the immune system, and it will interfere with your efficacy of management. So we need to address all of that, and we need to benefit from all the resource and help the patient in all aspects, including way that if we can help them financially as well, or make their life easy and decrease the stress and the cortisol production that kind of causing the dysregulation of the immune and redox, possibly the metabolic. And the production for the future of CDPM. And also, we're going to talk about clinical conditions and, the diagnostic and therapies that is, especially here, we will talk about the main and common conditions and also those high-tech innovations, whether it's diagnostic or treatment. We may end up producing more chapters in this book as we go. Everybody's happy here?
Yeah, one question.
That's fantastic. Literally.
Love everything questions? Here. Yeah, I got one question. How come number 13 isn't last?
No, 14, right?
Yeah, why isn't 13 last?
Because obesity, metabolic syndrome, and estrogen dominance, I think 60% of, maybe more, of adult population, especially after COVID, you can say 70%, we have this problem.
No, I understand all of that. Generally, when you go through something like this, when you talk about the future, that's the last thing you talk about. But I don't know. It doesn't matter, I guess.
Yes, I know, but
it seems a little out of sequence, Doc.
It's up to you guys. If you want me to plug it in, it's just I'm giving you this. Those 13 chapters. It's more of
I got it
generally, but when you go to we want to give some sort of specificity for things that is common, that needs more detail, that's difficult to categorize, cover it in one chapter. Like this to be covered, obesity, it involves things that we learn from chapter, from the oxidative stress, from metabolic, from the immune, from regenerative, has to be combined. But we will definitely work on, if it's something that we can plug it into the 13 chapters, that's good. If not,
no, that's
well, you could say emerging. Yeah, you could say emerging or additional areas to be concerned.
Oh, we can put it under 13.
Yeah.
You mean?
Just okay.
I would just switch 13 and 14. That's all I'm saying.
The numbering just sort of, it ended out of sequence. That's just from my end.
Okay.
And I think Quinn says the same thing. So otherwise, I like it.
There's something else you can do, Dr. Halassa, like a lot of others do, especially for advertising the main book. How about if you put 14 into an ebook to advertise for the rest of it in the future?
Yeah, that's possible. Because I put the detail of the 14 is here. And that's what we're going to go through it. If you still have energy and interest. What's the time now? How many time? Is it 1 hour?
Yeah.
5:41.
The question is that, do we want me to continue, or do you want to have another session?
I think we continue.
Everybody in favor of continuation?
Yeah, that works. Maybe we don't need a 3-hour session, but I think there's still, we haven't had questions and answers, but I think this is fantastic, really, truly.
Right. Do you enjoy it? Because I don't want to lose the spam, or in other words, attention. I want to make sure that you're on track with me, because I want you to be involved in previewing this book and be critical so that we can perfect it. And I'm listening to all of you here. So if you have any points, any additions, any explanation you need to add, please raise your hand and talk. Interrupt me. I don't care. I need the interruptions, because it's more fun when there's debate and discussion versus one way. It makes sense?
Yeah.
Anybody has questions?
Yeah. Well, I have one comment on this, and like Dr. Joseph said, I think this is just absolutely phenomenal. What keeps jumping out at me is where I'm seeing a difference between this and mainstream medicine, and you talked about that just a little bit. It just seems to me that the CDPM is more or less a multimodal approach to overall health and wellness, whereas mainstream medicine is more organ system targeted diseases.
Right. But we're going to use both sides of the body.
We're treating the whole body. We're treating everything. We're not just saying, oh, well, diabetes, okay, that's a pancreas problem. No, we don't do that. We're treating the whole body with a multimodal approach, everything from light therapy to anything that you can think of, PRP, nutrients, detox. It's a total body health and wellness makeover that should not be stepping on the toes of anyone, as you said, because nobody is going to say, well, you know what, you're stepping on an endocrinologist's toes. We're not doing endocrinology. We're doing overall body health and wellness.
Right, and also management, and we use the tools that we learned from the medical school. So I'm not savvy integrative, nor I'm savvy regenerative. It's like the politics this day, Republican, Democratic. You can say I'm the independent, using both the best.
Yeah. Right, Dr. Alasa.
Yes.
Yeah, Dr. Klotz here. Another thing that people may want to make themselves aware of or avail themselves of is the forum at worldhealth.net, because we could use that as a question answer platform 24/7, so it doesn't just have to be when we're online.
Right, and I would recommend everybody. Can you put the website?
Cool, great idea.
Yeah, love it.
Can you put the website? And if you have, I think you have assistant with you, maybe they can come, Jeremy here, and help me up promoting the word health here, and so we can get everybody here on the board.
It's really easy to get onto it. It's really easy. Just go to forum.worldhealth.net, and it's nothing to sign up. There's no cost to it. I think you just have to put in your email, and you're there.
Great. So please do, everybody here. This is more of a platform of collaboration. So if any of those doctors of the CDPM and those recognized doctors who are interested to add any of their own projects, or they have ideas, please share them here. We are open to entertain anything that helps to improve the quality of a patient's life and the education and innovation and redefining medicine in general. So if you go here to the introduction of chronic disease prevention and management, chronic disease prevention and management represent comprehensive approach, as we talk about, using the tools of both sides of the aisle to healthcare and integrate various modalities. Whether it's integrative modalities, off-label or labeled, for us, does not matter, as long as it is reasonable, it is safe, it's not toxic. And that's why when as doctors of chronic disease prevention, we try to use and screen what is the less toxic of those drugs that we can use, how I can use the lowest dose we can do and have all the effect, how I can use multi-therapy versus monotherapy, where I can use less dose of each, so that I will not interfere with the metabolism of the body and interrupt something else that will cause side effects. And also how we can get this medication to the target using platelets nanoparticle as a way to deliver those medication to the pathology versus going everywhere and causing side effects. So that is the approach of chronic disease prevention management of both eye.
Just something.
Or
go ahead.
Label. Yeah, go ahead.
Just wanted to add something just for education here. The big aha I had is this area when it comes to drugs. You have hardcore drugs, and it seems like the hardcore drugs that have all the side effects, perhaps they are larger molecules. They're larger molecules that it's like when you're in a car and you slam on the brakes to stop, or you slam the accelerator, and that there's always a problem with that. But there's this space between drugs and peptides that are small molecules, and they behave like peptides. Like you said, they dampen, they modulate. That's where I think these off-label drugs really fit, like selegiline. Increases dopamine. It's been used for Parkinson's for political reasons. It just gotten forgotten. It has been forgotten about. The new medical students don't have never heard of it. And this is increasing dopamine in the brain while reducing or while buffering the redox, which leads to reducing neuroinflammation. And it does it gently. And it's been shown to extend life. And there's a book about it. Okay. And then I saw the same thing, like Amlexinox. It's a small molecule. It's modulating those major inflammatory pathways at the, I would say, the master regulators. Whereas, there's TNF alpha blockers that are blocking. It's like attacking middle management and attacking it like harshly, like slamming the brakes. But these small molecules, I think it's important for us to almost open that up into a category that is understood, that becomes a part of our language, because that's where I feel like that's the go between the middleman or middle woman between holistic wellness. And when you have people that they've gotten to a point where I call them wild cards. You can throw a wild card in there. They're safe. They're not all natural, but they behave all natural. And that's it.
No, I agree with you. We need to screen when we come up with protocols. We need to make sure we use the drugs that is less toxic and supplement that is more safer. And then if it doesn't work, we go to the next level because, okay, this doesn't work. Let's go with more stronger. Yes. And if it's a little bit toxic, then can we find a way to minimize the toxicity there? Like, as I said, Ozempic does cause pancreatitis because it causes oxidative stress in the pancreas. Okay. And we talked about just before we come, I think before most of you here, that can we do pharmacogenetics to screen out the patients who cannot tolerate Ozempic? That would be a good approach. And then still, we can give things that helps to make Ozempic more safe by giving them N-acetylcysteine, by giving them KPV, by giving them thymosin beta, or the other one, which is the B157. What's the name of it? BBP 157. All those ones, and they're already being done by the compounding pharmacy. Some of them may help to neutralize those free radicals and work on the side effects. So that's where chronic disease prevention management protocols is also, when you give those drugs, we need to know the mechanism of action, the pharmacokinetics, and also the side effects, and how we can minimize the side effects by adding supplement that helps to reduce the toxicity of that drug. That is the uniqueness of this field of medicine. And also, if we can implement pharmacogenetics to make sure this drug is personalized, less toxic to this patient, then that will be another level of personalized medicine that we want to entertain as chronic disease prevention and management physician. Now, again, this introductory chapter will define CDPM, highlight the need for integrative approach, and provide an overview of the book structure. Defining the CDPM. Again, CDPM is not the word that I invented. Well, yes, in the beginning, it was something in between me and American Medical Association. At that time, I just want to find a name that is, that explain the integrative, holistic, and integrative and regenerative, and not use those things because those names are being kind of red flagged by the mainstream medicine. And as I said, American way, sometimes you need to explain the word, what it is. And so I come up with chronic disease prevention management. And coincidentally, it seems like American Medical Association felt the same, and they come up with this word and this abbreviation, CDPM. So we will see in the future that there will be CDPM specialists. Like pain management is a new specialist, by the way, comparing to other systemic diseases. And CDPM will be also an emerging specialist. So it's an emerging specialty that focuses on long-term care of patients with chronic diseases. And we know the 4 pillars of this specialty, right? Metabolic, immune, redox, regenerative. It aims to improve the health outcome by combining the traditional medical treatment with lifestyle interventions, patient education, and complementary therapies. So we're going to use both off-label and label for both sides of the aisle, integrative medicine protocol plus the mainstream medical record, whatever that is less toxic, that is more effective, that is more comprehensive, that is more personalized, that we're going to use it. The need for integrative approach, and again, as chronic disease prevention management affects many systems, it's multi-systemic disease most of the time, and we need to take or use the integrative approach, right? Screen all the free radicals and inflammation and start optimizing the metabolism. So this is an integrative approach in CDPM is essential to address the multifactorial nature of chronic diseases, right? Like diabetic mellitus, it's a glucose, it's a free radical generator that it can mess up with all the systems of your body. So we really need to address all of it as much as we can, and screen any other sources of free radical that would aggravate the diabetic mellitus, that will compromise the insulin sensitivity, and that include screening the for any leaky gut or toxins or fungus infection, or managing any underlying inflammatory or chronic disease or infection. And so involve collaborative effort between healthcare providers and patients to tailor the treatment that consider all aspects of individual health and well-being, right? Stress, the 3W: work, wife, and workout. So all of this needs to be addressed, the lifestyle and exercising and the stresses that coming from the family, social, work stresses. All of this needs to be collected. That's why with this mirror of Miss Abby, we can really reduce the time for the doctors to be asking all those questions and have a robot do that for you, and audio, and collect this information, put it in front of you on screen. So before you go to the patient, you know everything about patients. You don't need to go ahead and spend 1 hour or 2 hours asking those questions. Yes, you can go ahead and confirm it with those patients if you feel that there's some questions not being answered correctly and there's some conflict, because when you go through those questions, you'll see it makes sense or not. And if so not, you go ahead physically and you talk to the patient. Still, you have to have this physical contact with the patients. That's the one other thing we need to understand, because those patients sometimes they have malingering, they don't really they have purpose of changing their history for some reason. So all of that needs to be, with a doctor with skills, you can know whether the history is consistent, it makes sense or not, and also by physically shaking hands with patients and start asking the right questions. But it will save a lot of time. At least you cover all the basics. Overview of the book structure. The book structure is to guide the reader through a principle and practice of CDPM.
Just want to add something really quick.
Yes.
Because we discussed this as well with Abby. Is the other thing is the physician stress, and this idea that the AI can sort of take the information from the patient, or even the doctor-patient interaction, and translate and transcribe it into a medical record. Okay,
right.
That's a SOAP note, or in the proper format. I think that would be huge. A big deal, because part of the other issue is this doctors having to burn up all their energy trying to fulfill the medical record part in an environment that now is just not conducive to that. We need to reserve our energies for the patient care, the thinking, the innovation, the intuition, not spending all of our time doing computer input. I'm not, for me, that's the worst thing that could ever happen to me. I can never be a computer programmer, and that's just, might as well forget about innovation, because my batteries will be dead.
I agree with you. That's the reason after this thing, then you have your phone, an app there will record all the interview between your patient. There will be some AI, and they will fill up the formats based on the answer and the interview that happened between you and the patients. And that will be including from history, physics exam, diagnosis, treatment recommended, the AI will recognize all of this words and put it in a very nice report, a professional one, right? And with all the grammar and the right terms and words and all that, perfection, right? And that is what we are looking for from the people with the digital capability and AI. Because if other luxury things, it's okay to be added, but this is the unmet medical need. This is the gap. This is what we want. So again, you make your products around medicine, around real medicine. You don't create medicine, and most of the time it's luxury and not really, it's complicated, around your products. Okay, that's something we need to emphasize on it when we are, trying to get the AI helping us, not making things more complicated. So again, the book structure to guide the readers to a principle and practice of the CDPM. I think we talked about the pillars of the CDPM and methodology and approaches. It include chapters on science behind chronic diseases, the pathophysiology, evidence-based treatment, everything here in our platform. We have to understand the mechanism of action. We have to understand, the side effects, the pharmacokinetics. We have to understand the data, the epidemiology, all of this. And it has to make sense, those protocols. And we don't just say, oh, it works, but we don't know how it works. Shooting in the dark, that's not in our field. And that's not in our platform. Even if a doctor is coming in and he's trying to entertain some treatment, but he doesn't know exactly how it works, either we help them to explain how it works, or we ask the doctor, hey, there is no much of evidence there, so we cannot adapt this protocol in our platform until you have a clear explanations. Because me and Dr. Jusuf, we met with a lot of companies producing, gimmicks, and nothing has to do with medicine at all. Like that, I think Dr. Jusuf remember one of those companies. She brought me a bottle of a glass that looks like an ashes. I don't know if a dead person, but it's a supplement, herbs, spices. And she say, we expose this to all the treatment, the light therapy, the electromagnetic therapy with certain dosage. And then this thing absorbs the quantum of these treatments. And if you go ahead and you put it next to you, this ashes of spices, then you get the benefit of all the treatments that we insert in it, not physically, but quantum. And of course, this is a joke, but this is what's happened in reality. Got me so turned off. Of course, as an INTP, that is where I will drive me crazy. Like maybe I will not sleep at night, maybe 3 nights, and start cussing and cursing the day I went to that conference.
And it cures autism. I mean, that's what she said.
Everything. Exactly, it cures everything. And many. I mean, there are some doctors that they have a lot of followers. I don't want to mention my name, and he said if you shine the light in his foot, it goes to the microtubules and it goes all the way, comes out from his head. And he said the memories does not stored in the nervous system circuits of neurons. They are stored in the microtubules of the whole body. So that means if you have memory that is in your left arm or your finger, that's being stored there in the microtubules, and something happened, it being amputated, that piece of memory, you lost it. So anyway, a lot of gimmick out there, they're trying to use those big words, quantum, digital twin, all those big words. It's really more or less is to create that that kind of unknown thing that we know better, that we are
mystery
intelligent to understand it. You cannot understand those things as quantum medicine. This is metaphysics, and this is something you can feel it spiritually and all that. So definitely those gimmicks and games and false marketing and what we call it, this can definitely hurt patients, can kill patients. Because if you said to me that if I shine a light on a medicine like insulin, and then I don't need to take the insulin. Just shine a light off it, and the light will take or carry the quantum function, quantum benefit, the whatever quantum function of the insulin by light to your body. So expose the light, just put the insulin between the light and your body, and the light would carry the benefit, the treatments by light, by quantum to your body. So you don't need to take the insulin at all. You just have to shine the, and the insulin will stay for long. Of course, the big pharma will be so upset because then you will stop prescribing insulin. Well, at the same time, the patient would die from hyperglycemia, and so you have both sides. It's a problem. Patient would die, and big pharma will be pissed off, and so it's completely wrong to say that. And then everything you can do this except the things that I'm promoting, which is the detox. The detox, you need to take it physically. You cannot just shine the light because I'm selling it. But the whole rest, you can go ahead and just shine a light on it, and you get the quantum healing of that drug. You don't need to take it physically. And those information, those misinformation, it can be easily adapted by the nurse, well, by those, we call them nutritionists or whatever, the one that have 1 year after high school, and you become called doctor and physician, versus 8 years of us or 7 years of us, in medical school, and then 3 years of residency, to just be called a doctor. And those people from high school, 1 year, 2 years, and they being called doctor, right? And those people, they can prescribe. And the person who spent all this time, they have to go through all the stupid certifications and license in order to prescribe one drug. So it's corrupted system there. And that nurse, she will learn from an MD this methodology, and she will adapt it, and she will be advising it to the patient. That misinformation can kill. There's some misinformation I can say it's okay. I mean, it's by intention, but those misinformation can really kill the patient. So what do you think, doctor?
Oh, yeah. So as you were saying that, I just wanted to put perspective onto it, because I know that quantum is, there's something there, obviously. And I think the way to differentiate what we're doing, and we'll just say energy medicine, it's not that energy medicine doesn't have any value. You know what I mean? It's that if we're going to give a patient a treatment plan, there needs to be a logic to it. And if, say, there is an energy therapy that it's not explainable, I guess. I mean, obviously the one with the dirt in the little jar, and I mean, you could tell she's just that type of person, doing that. But she probably is very soothing. She probably has a way with clients, and as long as we communicate that to the patient, say, look, there's energy medicine. I can't tell you for sure exactly how it's going to affect your particular disease state. Okay. But say for example, it's something that really is legitimate, and people have, said that they felt better. Because there's some things that we just can't measure, right? But we just have to be clear that, look, I don't know exactly how this works. Certainly, if you want to try it, it won't hurt. And some people say it makes them feel better, and if that's the case, that's perfectly fine. We just need to be clear on our therapies and understand the mechanisms of action. We're not just throwing peptides blindly at them, not really truly understanding exactly what they do. I think that's the biggest thing, is to get clear and to get our thoughts organized around redox, immune dysfunction, and metabolism and regenerative status. That has helped me in ways that I can't even describe. I've never had an organized way of thinking like that when approaching patients. If I were to go back and think about how I thought about patients earlier in my career, I would say it was very surfacey, and I had a lot of unanswered questions and confusion. And my choices were always sort of incomplete or targeting just one thing, but there was never this complete picture. And what you're doing is you're providing a language, a logical language, for this bigger picture so that we're not shooting in the dark. And then for the areas of therapies that exist out there that do not necessarily have the mechanisms that we need, we just need to be clear that we just don't know the mechanism. But it certainly, if it's something that's helping people, you know, that can be a part of the therapy as long as we communicate that to the patient. Let me interrupt
you here, Dr. Joseph. There is nothing that me as an INTP, Dr. Klatz as an INTP, and you as an ENTP cannot be explained. We can't explain anything. Those light therapy, those electromagnetic waves, all of them do work on the body through a field. It's called redox medicine. You know the redox medicine, you can understand how sonotherapy, shock wave, you know, like electromagnetic waves, phototherapy, acupuncture, name it. All of them works through redox medicine, all right? And we can explain it. There's nothing that we cannot explain it. But if there's something that is unexplainable, it's unexplainable, okay? It's just no, it's not there. It's not. And if you say, well, it's helping patient, that is placebo effect. It is real, it's helping. If I, Dr. Yusuf, if I tell you that this drug, it's going to help you and you will feel good, and you believe in it, that this drug is going to help you, and it's only water, right? And if you drink this water, it will help you. But the faith and belief this is going to help to help you will increase your oxytocin in your body. Once you drink it, it will increase because of the anticipation of this is going to help you, this is going to heal you. Your brain will work by secreting oxytocin, and that oxytocin itself will cause some sort of healing in your body. Yes, there is chemical change, just the faith and belief. That's the reason people, when they go to the church or to or the place where they sing and have fun, and their parasympathetic is high, the dopamine is high, the oxytocin is high, definitely they don't feel the pain anymore. Like they will throw their whatever stick or can in their hands and they start dancing as they don't have any joint pain because of oxytocin. It's definitely helped to give them that analgesic that it resets the body. And so it's very important that, you know, being in a good mood, being an oxytocin mood. And I hear from A4M, they present oxytocin. So that's something good. I like it. And I do recommend oxytocin a lot because it's the happy molecule and it's the healthy molecule. It's just like when you have a computer is being corrupted and you want to reset it, you press the reset factory. Oxytocin in our body is that reset factory. Okay. And so, yes, so we need to make sure that we understand that even if this person say it works and it's a gimmick, but still the patients are happy with it, understand the mechanism here is through oxytocin, right? And I think when we went to A4M this time, that lady or the doctor present oxytocin, she's also saying, she come up with a term called oxyplay, which is, you know, having relationship with your partner. That will increase oxytocin and definitely can help to glow your skin, can slow the process of aging, can decrease inflammation, as antioxidant, can kill the cancer. So happiness and a good mood, it's the way you go, because the stress and too much of cortisones and suppressing the immune system, especially shifting the immune system away from Th1, will put the patient at risk of infection and cancer, and oxidation and aging will progress. To block the aging, be happy, be healthy. I think that's the best word to use. It makes sense?
Yeah, I understand. I understand what you're saying. By the way, I really do. I guess what I'm trying to say is if the practitioner if they don't know what the mechanism is, you know, it doesn't mean that they cannot try it or have the patient try it. If the patient wants to try it, they just need to be clear with the patient that they just don't know the mechanism, even if it is oxytocin is the mechanism.
If they don't know the mechanism, they will come to Dr. Joseph James or Dr. Klatz or the CDPM physician here, and they ask them, because that's what we are here for. And we learn from each other here. And we definitely, we want to be the frontier of medicine. and help the doctors to understand all this difficult mechanism of action, especially when it comes into energy medicine. And I think we have a chapter for that. Is that good?
Yeah, great.
All right. So chronic disease prevention management indeed represents a comprehensive approach to healthcare, and that emphasizes the importance of understanding and addressing the complex interaction among physiological systems to prevent and manage chronic disease effectively. And the focus on redox balance, metabolic pathways, immune system function, and regenerative capacity is the crucial for tackling a multifaceted nature of the chronic diseases. Most of the chronic disease conditions, they will have those 4 factors, and you really need to work in modulating and restoring it. The Center of Control and Prevention, the CDC, also highlight the significance of preventing chronic diseases through various strategies. According to the CDC, many chronic diseases are caused by key risk behavior, stress, and making healthy choices, including choices individual can reduce their likelihood of getting chronic diseases, right? Lifestyle change, exercising, stopping smoking, drinking, stopping all the bad habits, and improve the quality of life. The CDC promote chronic disease prevention efforts in key areas such as epidemiology, surveillance, environmental approaches, healthcare system interventions, and community program linked to the clinical services. CDPM approach to personalized, very important. It's going to be personalized based on the data of the patient, from the history, physical exam, genetics, and is indeed in line with CDC recommendation for managing chronic disease such as heart disease, type 2 diabetes, and many chronic diseases, including cancer. The CDC emphasized the importance of lifestyle changes and as a cornerstone for preventing and managing chronic conditions. So it's not good enough if you are taking all these medications for diabetes and you're not optimizing your health. You're not decreasing the exposure to the toxins. You're not taking the right nutrition and doing the lifestyle change, which is exercise, because exercise promotes the expression of antioxidants genes, right? Because exercise is causing physiological stress, and physiological stress, your cells will respond to it by expressing the growth factor, the antioxidant enzyme, to combat that physiological stress as a response. And so lifestyle change, exercising, stopping all this smoking, good sleep, antioxidant therapy. So here how CDPM strategies align with CDC guidelines. Definitely we recommend antioxidant therapy, right? Because when we grow in age, what would happen? Your genetics that express antioxidant, they get shut down epigenetically first, and the pro-oxidant, they get expressed more than pro-oxidants, and that leads to more free radicals that's being imbalanced. So here you need to give supplement, not just to neutralize the free radicals being generated chemically, but also to stimulate your genes to produce antioxidant enzyme, to stimulate the epigenetics, because we can modulate the epigenetics to express more of the antioxidants, so we can keep the balance, so we can slow the process of the aging, and we can slow the process of the progression of the disease. So antioxidants help to neutralize free radicals in the body, reducing oxidative stress and potentially lowering the risk for chronic disease progression. Nutritional intervention, a balanced diet, which includes vegetables, whole grains, lean proteins, and low-fat dietary products, low carb, while limiting adding sugar, saturated fat, sodium is a key to managing chronic diseases, especially low carb. Definitely does not mean low carb means you eat too much of fat. Reasonable amount of fat is okay, but too much also, it's not a good thing. But very important is low carb, because what we find out that the damage that's happening in blood vessels, it's because of the sugar become oxidizing glycans, free radical generator, and then they start oxidizing the endothelium, right? And when it's oxidized, damage, you have inflammation, little inflammation there, oxidative stress, the activating the macrophages, and then the macrophages with oxidative stress with the free radicals will oxidize the fat, and that leads to deposition of the oxidized fat, which is oxidized LDL, into those area and causing the atherosclerosis. So first thing you do is low carb and also low fat, but still what's important is low carb. If you do low fat and high carb, it's not good. That used to be the recommendation before, right? Low fat, and they eat all the sugar. Well, what happens is the damaging that's happening in blood vessels. It's not really does not start with the fat. It starts with the sugar oxidize and become free radical generators. And then that oxidized glucose oxidize the fat, become oxidized LDL, and that deposits into the tissue. But if you have low carb and reasonable amount of fat, you're okay, right? Because the fat, the cholesterol, eventually will be used to produce, of course, your sex hormones and cortisol, all that. So cholesterol is not bad. It's not a bad thing. It's part of your membrane. It's part of your sex hormones, but you don't want to oxidize them by adding too much of sugar. And that's why what is the most dangerous food is the sweets, the cake, which is a mix of two things, fat and sugar. That's no, because sugar will be oxidized and oxidize the fat, and then the oxidized fat will deposit into the blood vessels and causing this problem. So avoid cakes as much as you can. And if you are craving sugar or carbohydrate, then take acarbose, that's being integrated in the capsule, which with other things, of course. Dr. Mike Emanuel has them. So lifestyle modification, regular physical activity.
Quick question.
Yes.
So when you're saying that the sugar gets turned into glycans, it becomes oxidized, you're talking about inside of the bloodstream, and that it's having a toxic effect on the cell wall of the endothelium?
Yes, so sugar, there will be oxidized sugar in the bloodstream, and they will oxidize the membrane of your endothelium, the fat, whatever. And the fat we call oxidized LDL. When it's oxidized, it's going to deposit, and then those oxidized sugar also will irritate the macrophages. There will be inflammation and shift, and have some active Th17 there, and M17, and that leads to the whole inflammatory process, and then fibrosis. That's another thing you have to know. Those atherosclerosis, there will be also inflammation, narrowing, and also there will be fibrosis as well. That's why the best drug that I would recommend for atherosclerosis is losartan, because losartan is antifibrotic. To manage atherosclerosis, it's good to also recommend losartan, even low dose. That does not change much of the blood pressure.
Which also happens to be a small molecule, by the way.
Right, exactly. Immune modulation, managing inflammation. Again, modulate as much as you can before you suppress. But in case if it's too much, you can use the steroid to reset the immune system. But modulation is an art, and I think Dr. Joseph James and Dr. Patel, they are mastering it by checking the cytokine profile and the map and do all the ratios. And they start, okay, well, there's too much of Th17 and Th1, so let's go and try to give drugs that helps to inhibit Th17 and Th1, the natural ones first, like naltrexone, and try to shift things. Right, and if they have too much of Th2 and Th17, let's move them to Th1 by giving thymosin alpha. If they are too much of Th1, Th17, let's give thymosin beta. And so they understand now how to modulate and shift the immune system left and right by using those tools and protocols that we recommend in our sessions here. That is something I think Dr. Giovanni, he's developing those diagnostic testing. I try very hard to bring him on the table. I don't know if Dr. Klatz can reach out to him and bring him to the table here where we can work together and join forces. That would be great, because I do recommend lymphocyte mapping in case the case is very complicated and we need to know the immune status and how we can modulate which direction instead of shooting in the dark. But I have a hard time to bring him on the table. So I know if you have any doctors here who has in touch with Dr. Giovanni, tell them this is the best platform for him to really explain how is diagnostic, the medical necessity of his diagnostic system. Redox medicine, it's a branch it has in academies and it has a society. But most of the people in redox medicine, they are PhD, they're not MDs. Because the MDs, they really don't have any clue what's redox because it's not in our curriculum. But the PhD, they see the significance behind it, and they have a hard time to translate this information to the MD because it's not in their curriculum. And so they don't see it as real, some of them, some of them, especially those big pharma oriented. But it's a real field of medicine. I used to first, when I came up, I mean, first I was labeling my field as a redox medicine, but then I find out it's not just redox, it's also immune, it's regenerative, it's metabolic. And I want to have something that become inclusive, contain everything. And so I end up with CDPM. That's the last update that I have. But I went through redox medicine, and I used to be calling the field redox medicine, but redox itself is not enough to be controlled to manage chronic diseases. You really need to work also on modulating the immune system, regenerative status, and metabolic to get the comprehensive treatment. Metabolic therapies. Yes.
I do want to add something. This is just from my clinical experience over the past 3 years in learning this language, is that I get a lot of patients from all over the country. They reach me by phone, okay? And the common story is that they, first it was their regular doctor. That didn't give them, didn't get an answer there. Then they started going to the specialist. They didn't get an answer there. Then they went to the Mayo clinics and the Cleveland clinics, and they didn't get any answers there. And then they're going to the pop-up functional medicine places that is, having at least some alternative things and doing some different kinds of labs. But even there, they're not getting better. They're getting at least partway there. But the reality is, because I can speak this language, I can pinpoint better what's going on and what to do about it. And I find myself even if there's a good functional medicine doctor that they found, a lot of these chronic, these multi-systemic diseases, that the patients that have them, especially if they're having like mold toxicity and maybe some heavy metal toxicity and activated Epstein-Barr, where everything just gets so confusing, especially if you don't have your thoughts organized around them. The functional medicine doctors have put them, at least this one I spoke to today, had her on some pretty good treatments. I was like, that's pretty good. But I was able to pinpoint where the missing links were. Because the problem is, it's like, yeah, she feels halfway better, but she's still, this is in my patients now. Again, I told you who I attract at that meeting. That's just this is just the way it goes for me. She's managing millions of dollars. Like she runs teams that manage, a lot of money. There's a lot of stress. Obviously that's a piece of the puzzle too. But I'm able to fill in those gaps where there's still some missing pieces because my thoughts are organized about what's going on. I don't have this sort of confusion and this need to sound like I know what I'm talking about. You know what I mean? I actually can see where the missing pieces are, or if they haven't had a lymphocyte map or something like that, it's like, look, we've got to get this test. It gives us 15 windows into the immune system where you can see all the dysregulations. You can see if the CD4 count is low. They might be on some sort of a thymosin troche, but if I see that could increase the CD4 count, which is common, by the way, with COVID, because it behaves like HIV. The literature that I've been coming across, HIV and COVID are basically the same for the most part. And it's like, well, then we need to know this, number one, that you're still immunosuppressed. Okay, that's part of the immune dysfunction part. And perhaps we need a more robust approach to get that CD4 count up, and T cells in general, so that we can get those other pathogens back into remission. Because we're not going to get rid of Epstein-Barr. We have to build up the immune system, the a particular part of the immune system that will put it back into remission and will not be contributing to all those inflammatory cytokines that are leading to the fatigue and body aches that she's having. And then, something like, because we have expertise with all these modalities that they don't think about, like, she probably has sinus biofilms that are not being addressed. And we know that if you use like a methylene blue nasal spray, in fact, I actually recommended oxytocin combined with methylene blue nasal spray, followed by an intranasal red light. Now that's been shown to help to eradicate biofilms, especially if it is combined with a liposomal solution, because the liposomes will penetrate better the biofilms, and that's in the literature. Okay, right. So that's my point, is that it's how we think about these very complex situations, and also realizing that, look, we're right at the front end of this stuff. I mean, it seems that nobody's at our level, literally, because I keep coming across, or maybe I just don't know, but the ones that I come across, they've gone to a lot of, when they go to functional medicine clinics, they're not just average functional medicine. I mean, these are the big ones with the big names, because my patients don't go to small name places. They go to the ones with the big reputations and all that stuff. And again, it's deceiving, because sometimes the big reputation, it doesn't mean that they understand mechanisms of action. Because like you said, that's a PhD world that you have brought to the clinicians in order for us to actually see and know what we're doing, because we understand the physiology like a machine.
Right.
I agree with you wholeheartedly, Dr. Joseph. That was very, very well said. The PhD people deal a lot in theory and all of that kind of stuff. And this group, the CDPM group, are the people who translate the theory into patient care. And there's not a lot of people that can do that.
Right.
Thank you.
So again, I want to make sure that metabolic therapy is not just lowering the sugar or lowering the cholesterol or managing that blood pressure or weight loss. Metabolic therapies here, it includes optimizing all the metabolic pathways. So if you have deficiency of nutrition and you replenish that, deficiency of amino acid, phospholipids, whatever you do, it helps to optimize the metabolism, vitamin D deficiency, minerals. That is part of optimizing the metabolism of the body. And yes, managing diabetes, lowering the sugar is one of them, but it's not just that, but sex hormone deficiency. You have low testosterone, you're replenish them with testosterone. You have low estradiol, you replenish them with estradiol. So sex hormone. So that's part of the metabolic therapies that we are talking about. Regenerative techniques, regenerative medicine, including stem cell therapy, tissue engineering, platelet-rich plasma therapy, the biological nanomedicine, which is platelets-derived nanoparticles, loading it with drugs. All of this it's part of regenerative techniques and possibly targeted therapy that we are using the biological membrane, whether from stem cells or PRP. I prefer PRP because it's more efficient and more effective. Oops. Can you hear me, guys? Can you hear me?
Yeah, I can hear you, but lost your
yes.
video.
Yeah. My wife is calling. That's the reason. And got interrupted here. Anyway. Okay, so good. Okay, sorry for that. And so regenerative medicine, so it includes stem cell therapy, plasma, even targeted therapy, platelets, nanoparticles loaded with drugs and supplements that helps in regeneration. It can be categorized under regenerative medicine because we use the same protocols to prepare the platelets, nanoparticles, same like repairing platelets or stem cells. The CDC recommendation for managing chronic disease focus on prevention and control through healthy lifestyle, as we said. CDPM is personalized treatment, very important plans that incorporate these elements reflect a comprehensive approach to manage chronic disease, emphasizing the importance of individualized care that's based on the data that you receive from the patients, including the genetic data, right? It's very important so that you don't give the wrong medicine if the patient cannot metabolize it. And so employing genetics and pharmacogenetics and genomics definitely helps in determining the drugs choice that you're going to use for that specific patients. So tailored to each patient, unique and circumstances. It's important for individuals to work closely with their healthcare providers to develop the treatment plan and the best suit their health status and goals. And the integration of various therapeutic strategies that we talked about as outlined by the CDPM can help individuals manage their chronic disease effectively and improving the overall quality of life. I think it's enough for today because we can have a complete chapter on obesity, metabolic syndrome, estrogen, maybe the second session. I think people are tired here and maybe they have questions and I want to be overloading them. So are everybody's happy here? Hello?
Yes. Yeah, I think this would be a good time to, I think 2 hours is good. And,
yes.
Open it up for people can just, feel free to ask questions and then we can wrap up.
Right.
Okay. Can I throw in a couple ideas? This is like dealing with postgraduate topics. And we were talking about multimedia, and Joel said ebooks, and we could put a list of resources. We could decide whether we want to do print on demand or keep it in ebook format. A4M has a huge library of knowledge, and if we could leverage that in, that would be really good. And then we're going to do podcasts. And then we could, this could lead to CMEs and certifications and more knowledge, because once you get started, you want to keep going on your journey. And, you got to say, well, how do you acquire new doctors, new nurses? And, you want to have fresh blood. You want to have new people and have something where you have continuity, okay? And the focus is on truth and the art of medicine. And then you have resources like the Townsend Letter and Capital University of Integrative Medicine, Dr. Ali. And they, Townsend Letter needs more funding. Capital University, they didn't have funding, so they stopped. So you want continuity that's self-renewing. You want to keep the initiative going. You want to, keep reinventing things. And I think it's something that can be worldwide, because internationally, if you have worldhealth.net, well, the world and world health means we need to proliferate this knowledge in more than 120 countries. And I think that's exciting. And then we can benefit from research from different parts of the world. That research and knowledge doesn't just originate here, it's getting to be worldwide. So that's my 2 cents.
Thank you very much, and we will rely on you in editing the books, this book, so we can finish it maybe during this 2 weeks.
It's going to be exciting.
Yeah.
I volunteered to edit.
Right.
I volunteered to edit. Y'all know I'm a good writer. I'm great
at
editing.
Good.
Oh, good.
We can have you there as an editor. That's fine. Then Jill can pass to you and see if you can add anything from. Yeah, I know that you like the it's called the REM. Yeah, the REM. You're putting words in a balance. Yeah, maybe that would
rhyming.
Rhyming, yes.
Yeah, like drug poems.
Exactly.
Collaboration's great.
That's your forte, right?
Well, she's also a pharmacist,
Right.
PhD pharmacist, right?
PharmD. Doctor
Yeah,
of
she's a
Pharmacy.
PharmD. She can add.
Yeah, she can add. Yeah.
Well, she's an ENTP like me, so it doesn't surprise me. She's got those added elements to her logic. I was going to say, for the farm Ds, if knowing all the drugs out there, if you could find the small molecules, ones that are small molecules, and bring them to, we can bring them to the meeting, because I'm just sitting here thinking about what are all the other small molecules that they're not being used, or maybe they are FDA approved. Like, they're all FDA approved, but like dimethyl fumarate, small molecule, is FDA approved for multiple sclerosis. It just got taken off the preferred list in 2020. I guess, I don't know, it helps with the Warburg effect, and that could have helped people with the cytokine storm. So, they had to get rid of that one immediately. But they exist. That was a joke, by the way. Hope you're laughing. They exist. It makes
we are internally.
Right. It makes me wonder what else is out there. And I would think that the PharmDs, they would know. They would know better. They'd be able to find some that, hey, what about this one? What if we repurpose this? And then we look at the mechanisms of action together, and suddenly it's like, wow, because I'm telling you, you never know. I've just been blown away by some of these small molecules. And granted, obviously there's forces working against, the things like regenerative medicine. They got rid of half of the peptides, or all the good ones that, BPC 157, KPV, thymosin alpha, thymosin. It's like, come on, did you have to take the best ones away? If they're going to keep taking the peptides away, then, well, number one, we still have our small molecules. Nobody's even thought about that. I guarantee you. This is a category that I'm saying now should be a category of its own, that are already FDA approved. They're hanging out there amongst all the other drugs that we can still use. And also, will it be easier to expand? Obviously, if you're trying to expand a stem cell clinic worldwide, forget about it. The forces that be absolutely don't want that. They don't want anything that actually works. But because, like Dr. Halasa, you said, they've got the chronic disease, the AMA already has the intention in the category of chronic disease management due to all these systemic. All we're doing is doing it better, which still they don't want, probably. Well, I know they don't want, but at least it will be easier for us to do what we do, because we're virtually the same. We're just better. That's all.
Right.
It won't have the same scrutiny that that the peptides and stem cell clinics and stuff like that have to deal with. That we may be able to sort of, kind of get in there and without a lot of trouble. So that's it.
I agree with you. Any other questions? Any statements? Everybody's happy?
Perfect. I'm good.
Yeah, good, strong work. Real good. Real impressive and real exciting. A lot of great work there.
Great. Yeah, so we'll have the chapter of obesity, metabolic syndrome, and estrogen dominance next Monday. Is it weekend or something next Monday, or people are okay with
Christmas?
It's Christmas.
It's Christmas. Okay, so that's me. We will not.
Is that some sort of holiday?
Yeah, it'll be the week after.
It will be the week after, right?
Give or take, barring New Year's, but yeah.
New Year's Day. But then you have the New Year, right?
25, 7. Yeah. Okay, 2 weeks.
Is that New Year?
Yeah, that's New Year's Day. So unless you change it to
New Year's Day.
New Year's Day, New Year's Eve is the day you party.
Yeah, New Year's Day is when you recover.
But the day after you got hung over. Come on now.
You got to recover.
It depends on recovery, man.
Well, I would discuss this with you guys, you know, on the text, and if it's something, then we can schedule it. I don't think this Monday will be the right one, so we can just say, hey, this Monday is for you to stay home, have fun with your family, because it's the Eve day, and then the other one is Christmas Day, so it may be from here to 2 weeks, we will not have anything.
Well, the other part too is you could send the chapters, and we can edit them and go through them ahead of time. So it's up to you.
Yes, I already sent it to you.
That's a good thought.
I did send it to you. I will send it to you.
Send to me.
Yeah, I will send it to you. Anybody who wants a copy to edit to add, I have no problem.
Send it.
Is that good?
Yeah. And then okay. That's all we can do. I gotta grab an incoming on the other phone, so I'll talk to him in a bit.
Dr. Ben, I'm still here in Vegas. If you want to meet, come to Dr. Quinn.
All right. Well, let me do this. Let me deal with the legal mess. I'll give you an hour and a half.
Yeah, and Dr. Quinn, you may come because you know he get upset if we did not call him. Is he still there? Hey,
Quinn, are you here?
No, he's not.
No, he left.
Oh, Quinn. The Quinn exited stage left. Oh my God!
Yeah, if you like, you know, it's up to you, Ben.
Definitely.
If you want to call him, bring him. It's fine. If you said no,
I'll try.
It's up to you. Yeah.
I'll call him. I'll call him and I'll call you. Give me about a half hour.
All right. Okay. Anybody has questions? Bye. All of you are good.
Perfect.
All right. We'll be in touch then.
Awesome.
Dr. Joseph called me after we finished. I want to talk to you about what happened.
Sure. Perfect.
All right. Call me when you have time. I'm waiting for your call. All right. Take care, everybody.
All right.
Good night, everyone.
See you then. Bye.
All right, bye-bye.